Neoplasia. Here you see a scanning electron micrograph of a cancer cell. Note the blebs and characteristic microvilli. Introduction. How is it possible that any one of us can live several decades without dying of cancer? Cancerous cells are merely cells doing their normal thing, growing and proliferating. How could so many cells, around 10 trillion, do such an abnormal thing as inhibit their growth for many decades? This is a quote from Why We Get Sick. I'd like you to watch this brief video introduction right now.
Cancer is a group of over 100 diseases characterized by abnormal, uncontrolled cell growth. In a healthy body, cells grow, die, and are replaced in a very controlled way. Damage or change in the genetic material of cells by environmental or internal factors sometimes results in cells that do not die and continue to multiply until a mass of cancer cells or a tumor develops. Most cancer-related deaths are due to metastasis, malignant cells that penetrate into the circulatory system and establish colonies in other parts of the body. Great advancements have been made, but cancer is still the leading cause of death for people under the age of 85. In the United States, 1 in every 4 people die from cancer.
Outline. This presentation covers these first 3 topics in your text: terminology, classification of tumors, and biology of tumors. Neoplasia means new growth. It refers to cells that have escaped normal regulatory mechanisms and are now growing out of control. As these neoplastic cells proliferate, they can form masses called tumors. The words neoplasm and tumor are often used interchangeably. But not all neoplasms form typical tumors. For example, because blood is a liquid tissue, the neoplastic white blood cells that cause leukemia cannot grow into solid tumors. Neoplasms are also synonymous with cancer, a word introduced by ancient Greek and Latin physicians, perhaps denoting a tumor's tendency to recruit blood vessels around its central growing mass, like a crab with its legs extended outward from hard central body. Cancer is now the general recognized term for all types of tumors. Tumor means swelling, and the Greek term for swelling is onkos, which is the root for the term oncology, or the study of cancer. There are different methods for classifying tumors. The most important are called clinical classification and histologic classification. Clinical classification is based primarily upon the tumor's behavior, how it grows and spreads, while histologic focuses upon what the cells that make up the tissue of the tumor look like. Clinical behavior tends to correlate well with histologic characteristics, and both have been used to develop the criteria for classifying tumors as either benign or malignant. This diagram compares key features in clinical behavior and presentation that are used to classify a tumor as either benign or malignant. Benign tumors grow slowly and remain contained within an expanding capsule. This capsule maintains a clear boundary between the tumor and surrounding tissue and makes the tumor easy to remove. Because benign tumors are composed of cells that are all similar in size and shape, if the tumor is cut, its surface will appear homogeneous or uniform. In contrast, malignant tumors grow quickly and are not encapsulated. As they grow, they penetrate the surrounding tissue and are therefore much more difficult to remove. Because they are made up of cells of varying size and shape, a cut surface is not homogeneous. It may have areas affected by necrosis or hemorrhage. Finally, only malignant tumors undergo metastasis, wherein tumor cells spread from their original location to other places in the body by invading the lymphatics and/or blood vessels. This chart compares key features, microscopic features available upon histologic examination that are used to classify a tumor. Benign tumors are composed of cells that resemble the normal tissue of their origin. These cells are well differentiated, specialized for their function, with most nuclei of normal size and shape, and only a few cells engaged in mitosis. In contrast, Malignant tumors are made up of cells that do not look like the tissue from which they originated. Malignant cells are poorly differentiated, with few or no signs of any specialized function. Their nuclei are usually pleomorphic, which means they vary in size and shape. They tend larger to contain excess, unevenly distributed chromatin and prominent multiple nucleoli. All evidence that malignant cells are focused most upon rapid growth and frequent, uncontrolled mitoses. This photograph of a vaginal pap smear, we can see cells such as this one, with an enlarged hyperchromatic nucleus that dominates the cell relative to its cytoplasm, which is reduced to a narrow rim, such that the nuclear to cytoplasmic ratio is quite high. Here we see the chromosomes of a malignant cell that do not contain the normal diploid number of chromosomes. In this case, there are more than 2 sets of the 23, so it is considered polyploid. In addition, many of the chromosomes are structurally abnormal, the result of uncontrolled, disorderly mitoses. Such chromosomes are marked with arrows and designated with the letter M. Only malignant cells acquire the ability to metastasize. Benign tumor cells always remain localized. Although tumor cells may spread using 3 different pathways, by entering the lymphatics, blood vessels, or fluid in the body cavities, the sequence of events is basically the same, following the steps of what is called the metastatic cascade. Step 1 begins with the primary tumor. During step 2, cells that have acquired the ability to move and metastasize multiply and form a distinct, expanding metastatic clone. As this clone grows, its cells invade the lymphatics, blood vessels, or body cavities. Here we see the cells penetrate a blood vessel. The cells are then transported in the fluid from their site of origin to some distant part of the body. If they are traveling in the bloodstream, they interact with components of the blood and eventually form a clot or embolus. This clot adheres to the vessel wall and allows the cells to extravasate into or invade the surrounding tissues. If they find this new environment favorable, these malignant cells can attach themselves to this new location and grow into a new tumor. Of course, these malignant cells must be able to evade the cells of the immune system, or they will not succeed in colonizing another part of the body. Malignant cells are designed to grow fast and multiply. To survive and multiply in their new part of the body, they need a blood supply to deliver nutrients and oxygen. To this end, malignant tumors secrete various growth factors that induce the formation of blood vessels through a process termed angiogenesis. Because the cells of most benign and many malignant tumors still resemble the tissue of their origin, many tumors are named according to the cells they come from. Benign tumors from mesenchymal cells, cells of connective tissues, bone, muscle, are named for that cell with the suffix -oma added on. So a benign tumor from fibroblasts is called a fibroma. One from bone cells would be an osteoma. For malignant tumors, the suffix sarcoma is attached instead. So a malignant tumor from fibroblasts is called a fibrosarcoma. One from bone cells would be an osteosarcoma. Epithelial cells form the membranous tissue that cover most external and internal surfaces of the body and its organs. Benign tumors of the epithelial cells that line various glands or ducts are called adenomas. They are named for the organ from which they grow. Hence, liver cell adenoma and renal cell adenoma are names for organ-specific benign tumors. If the tumors form from the skin, bladder, mouth, or larynx, they are called papillomas. Malignant tumors of epithelial cells are called carcinomas. An adenocarcinoma, therefore, is a malignant tumor from the epithelium of the glands or ducts. Like benign tumors, they can be named for the organ from which they originated. Hence, liver cell carcinoma and renal cell carcinoma are names for organ-specific malignant tumors. For example, A lipoma is a benign mesenchymal tumor that originated from lipid or fat cells. Upon gross examination, it appears to be well contained within a capsule and made of tissue that is uniform in consistency. Upon histologic examination, it can be seen that this same tumor is indeed composed of normal-looking fat cells. Here we see another benign tumor, this time two epithelial tumors that originated from the glandular tissue lining the colon, called adenomas. Because they protrude from the intestinal mucosa, they are often referred to as polyps. Like other benign tumors, they appear well-defined, clearly distinct from the surrounding tissue. Upon histologic examination, the adenoma is composed of glands that appear uniform. This is a malignant mesenchymal tumor that originated from fibroblasts, the most common type of cell found in connective tissue. Called a fibrosarcoma, note its irregular, rough, ill-defined surface. Histologic examination reveals that this tumor is made up of cells that have acquired some characteristics of malignant cells, yet still resemble the fibroblasts from which the tumor originated. This would represent a lower grade, well-differentiated tumor. These line drawings show the microscopic features of A. squamous cell carcinoma, a malignant epithelial tumor, and B. adenocarcinoma. In both tumors, neoplastic cells with obvious malignant features are surrounded by normal, non-neoplastic connective tissue cells called stroma. There are, of course, exceptions to these rules for naming tumors. The ending oma, as opposed to sarcoma or carcinoma, does not always denote a benign tumor, and some tumors have special names. First, there are the liquid tumors of the blood cells and lymphocytes. The names leukemia, lymphoma, and myeloma always denote malignant neoplasms. There is no benign form for cancer that exists in the liquid tissues of the blood vessels and lymphatics. And tumors of neural cells have the special names of ganglioneuroma for benign and neuroblastoma for malignant. Also, a glioma refers to a malignant, not a benign, tumor of the glial cells, while a meningioma refers to a benign tumor of the meningeal cells. Finally, malignant tumors of the embryonic cells are often called blastomas. A teratoma is the name for a tumor derived from germ cells and can be either benign or malignant. Sometimes a malignant teratoma is referred to as a teratocarcinoma. Teratoma is from the Greek word for monster. A teratoma is formed from embryonic cells that differentiate into the three germ layers and go on to develop into an irregular, sometimes grotesque, mixture of jumbled tissues. This teratoma from an ovarian tumor, for example, even contains hair and teeth. Staging and grading systems have been developed for malignant tumors because the stage and/or grade may determine the prognosis and treatment. Staging is done through clinical assessment and considers the primary tumor size, T for tumor, the extent of lymph node involvement, N for node, and the existence of distant metastases, M for metastases. Hence, the TNM system has become the most widely used and understood system. Grading is done through histologic examination. Tumors are assigned numbers 1 through 3, where the most advanced grade tumors are made up of the least differentiated or specialized cells. Here we see a normal gland compared to a low-grade adenocarcinoma and a higher-grade, more anaplastic adenocarcinoma. Note how the cells in the grade 3 tumor have lost all specialization. They no longer look like cells that could function as a gland and are mostly larger in size with pronounced differences in size and shape of their nuclei. The biochemical differences between a normal and neoplastic cell are quantitative and not qualitative. In other words, a cell cannot be easily identified as neoplastic because of distinctive, absolute differences in its biochemistry. This is because transformation is usually not a sudden change, but rather occurs as a gradual process, as biochemical differences accumulate and become more and more pronounced over successive generations, until a normal cell develops into a neoplastic cell, and a neoplastic cell becomes increasingly malignant. In general, neoplastic cells are less differentiated than normal cells. They lose more and more of their specialized functions until their metabolism becomes simplified, focused more and more upon proliferation. The most malignant cells, therefore, retain only those functions necessary for survival and reproduction. Tumor cells acquire the ability to metabolize glucose anaerobically, and therefore tend to accumulate lactic acid. Because they require less oxygen, they have fewer mitochondria. As they have become less specialized, they no longer need to synthesize, process, and secrete specific proteins, and therefore they have less rough endoplasmic reticulum. Rapid proliferation, however, demands general protein synthesis to build new cells. Therefore, they have more free ribosomes. With their focus upon replication, the nucleus is larger, contains more chromatin, and has a larger nucleolus in order to make more ribosomes. Tumor cells may also regress to reacquire fetal features and therefore may produce proteins normally associated only with embryonic or fetal cells. For example, malignant liver cells secrete alpha-fetoprotein, AFP, while intestinal carcinoma cells produce carcinoembryonic antigen, or CEA. This diagram highlights the differences between a generic normal cell and a malignant cell. Note how most of these differences are a matter of quantity or degree. For example, compared to a normal cell, a malignant cell has fewer mitochondria, less prominent RER, more free ribosomes, and an expanded nucleus with more chromatin and a larger nucleolus. Furthermore, because individual tumor cells do not function as cooperative members of their tissue or organ, they have fewer intercellular contact sites and cell adhesion molecules. Malignant cells may also acquire a few qualitative distinctive features. As they assume more fetal features, they may produce and secrete fetal proteins such as AFP or embryonic glycoproteins such as CEA. Because little of these proteins are produced by normal cells, their presence can serve tumor markers, useful in the diagnosis and treatment of cancer. Finally, distinctive growth properties can be observed when tumor cells are cultured outside the body, or in vitro. Vitro comes from the Latin word for glass. Before the age of plastic, the earliest culture dishes were all made of glass. Compared to normal cells, neoplastic cells are much easier to culture and can survive in simpler growth media for a much longer time. Some malignant cells are even immortal, as they can undergo an unlimited number of mitoses. When grown in culture, normal cells will keep dividing until there is no longer any more room in their cell layer. Once they encounter other cells, they stop replicating. This is called contact inhibition, and it keeps cells growing neatly, confined to their tissue layer. Tumor cells, however, have lost their contact inhibition, and as a result, they pile up and grow all over each other. Most normal cells require a firm surface of attachment in order to survive and grow. This is termed anchorage-dependent growth. In contrast, cancer cells have lost cell surface adhesion molecules, and as a result, they tend to detach and float in suspension, forming rounded, spherical colonies. Neoplastic cells do not respond to the normal regulatory influences of adjacent cells, or to externally produced growth stimuli. Instead, Most tumor cells secrete their own growth factors, which means they depend only upon autocrine stimulation, or have developed overly sensitive growth factor receptors. These growth properties of tumor cells observed in vitro reflect tumor cell growth in vivo, or inside the body. In general, like cell growth in culture, the growth of tumor cells inside the body is excessive, unregulated, and disorganized. Thanks for watching.